and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator for MS Focus, and I'm joined today by Dr. Kalina Sanders, who will be discussing managing your MS symptoms. After her presentation, we'll open it up to your questions and comments. Now I'm delighted to introduce her. Kalina Sanders, MD, is a board-certified neurologist with Baptist Neurology in Jacksonville Beach, Florida. She completed her internal medicine internship and neurology residency at the University of Florida, Jacksonville. In her previous faculty position at UF Health Jacksonville Comprehensive MS Center, she participated in clinical trial research and resident education. She is currently with Baptist Neurology in Jacksonville Beach, Florida, where she is a partner in MS Care. She continues to participate in clinical trial research, including those targeting minority populations. She is a former member of the National Medical Advisory Committee and is the current chair of the Florida Healthcare Provider Council with the National MS Society. She has been treating patients with multiple sclerosis for over 10 years. We're very pleased to have her today to join us and to present this important topic. Doctor, thank you so much for coming, and I'm going to turn this over to you.
Awesome. Thank you, Deborah. I am always excited to have the opportunity to share information for patients and people living with multiple sclerosis. And so tonight I am going to focus primarily on symptom management of your multiple sclerosis. So we all know that multiple sclerosis is a chronic autoimmune condition in which the immune system attacks the nervous system. For about 85% of patients at the time of their diagnosis, they have what we call relapsing remitting MS. And the hallmark of this type of MS is relapses. Relapses have been defined as a new neurological symptom that comes and lasts at least 24 hours in the absence of a fever, becoming overheated, or overexerted. Oftentimes, relapses occur at least 30 days apart. But with each relapse, there can be the continuation of symptoms. About 10% of patients at the time of diagnosis will have what we described as primary progressive MS. For these patients, they have the onset of neurological symptoms and there's slow accumulation of disability over time without superimposed relapses. So when we talk about the symptoms that come from multiple sclerosis, whether you have a relapsing disease or a progressive disease, we like to think about it as an iceberg. There are things that are above the surface that other people can see. They may be able to see walking difficulties, hear your speech problems, or see extra movement such as tremors. But as many of you are aware, there are many symptoms that occur underneath the surface that other people cannot see. This may be your pain, fatigue, numbness, bladder or bowel issues, breathing problems, and cognitive difficulties. It really depends on where in the central nervous system your MS attacks that determines the symptoms that you have. For multiple sclerosis, we do have disease-modifying therapies. Our disease-modifying therapies have been shown in clinical trials to decrease the likelihood of having relapses. There also have been proven to reduce the amount and number of MRI lesion activity on the MRI, and do have some impact on reducing the accumulation of disability over time. But what we know that our current disease-modifying therapies don't do is repair myelin or allow regeneration of axonal loss that can occur with multiple sclerosis. And we know that they're not cures for multiple sclerosis. So because of this, people living with multiple sclerosis will develop symptoms that don't necessarily go away. So it is important that we understand how we can manage those symptoms to ensure that people living with multiple sclerosis have the best quality of life they can. As you remember in that previous picture, there are a lot of symptoms that our patients with multiple sclerosis can develop. Unfortunately, we won't have time today to talk about all of them. But I would like to touch on over the next 45 minutes or so on a few of them. I will talk briefly about fatigue, mobility issues, spasticity, bladder and bowel dysfunction, heat sensitivity, although now that it is getting into the fall, we're maybe seeing less and less of that, cognitive difficulties, as well as pain, particularly those that involve our cranial nerves or trigeminal neuralgia. So many of you may be able to relate to this meme or GIF. I remember doing PowerPoints before and we had to use clip art. So it's kind of neat to be able to use newer, updated images that really explain how people feel with multiple sclerosis. So yeah, it's like that. This is how many of our patients feel with fatigue, feeling weighed down. Now, fatigue is the most common symptom of multiple sclerosis. It is estimated to affect about 81% of patients living with multiple sclerosis. It can be considered one of the most worst symptoms our patients experience. About 55% of patients would feel that of all of their symptoms with MS, the fatigue is the worst. In general, fatigue is defined as lack of physical and or mental energy that is perceived by the individual or caregiver to interfere in the usual and desired activities. So this is more than just feeling tired, but you can push through. The fatigue that patients feel with multiple sclerosis impact or interfere in their daily activities. When we think about the causes of fatigue, we can think about it as low daytime energy versus poor nighttime sleep. So there are different things that can impact both of these, particularly for nighttime sleep, insomnia. So when you're not sleeping at nighttime, you're tired during the day or fatigued during the day. Frequent urination at nighttime can be a particular issue. And many of my patients do report some restlessness or discomfort in their legs that interfere in their ability to get a restful night's sleep. This could translate into daytime fatigue. Now, there are other symptoms that can occur during the day that can also result or contribute to fatigue. That includes pain, spasticity. We know that other conditions such as mood disorders, including depression and anxiety, can also have an impact on our energy level. And then there is something that we like to call HUTOF's phenomenon, or short-circuiting, an electrical dysfunction within the central nervous system that results in fatigue. But then there is lassitude. Many of my patients describe their MS fatigue as if they have hit a wall. With MS fatigue, this is a little different. This generally occurs on a daily basis. It may even occur early in the morning after someone has actually had a pretty good night's sleep. Unfortunately, this lassitude can progress throughout the day. Things do definitely impact it, such as heat and humidity. And one of the things that I hear all the time is it comes on suddenly. Like you're going about their day and boom, they hit a wall. and it's generally more severe than that normal tiredness or fatigue. And again, it interferes in activities of daily living. So, how do we manage the fatigue? One of the things that I like to chime in on or talk about with managing symptoms are lifestyle modifications. So you might see this as a theme throughout my presentation because it is extremely important. Lifestyle modifications can be helpful. One of the biggest things I like to discuss is setting priorities, getting rid of the non essentials. I personally am a big fan of delegation. So there may be things that you would normally do in your activities of daily living that you can actually delegate to someone else to do, i.e., children or spouses. But you also want to be able to develop a good routine where you are able to leverage your energy, being able to do the things that you need to do during the time where you know your fatigue is less severe. And then save things for resting time when you know later in the afternoon you're not going to be able to do it. Energy savers are also very important, using elevators, parking closer to the store, using assistive walking devices, particularly if your mobility impacts your fatigue. Eating well, keeping your body temperature low is also extremely helpful. And if you're a smoker, cessation of smoking is also important because we want to make sure that you have good oxygenation to your brain. Now, if you have done all of the things in your lifestyle to help to manage the fatigue, and there is still a significant impact, there are some potential therapies that are available. Having a discussion with your healthcare provider will ensure that you are on or placed on the right therapy. Some examples of things that we like to use to help with fatigue is amantadine. Many of you may be familiar with Provigil and Nuvigil, but there are also some small studies that shows that our SSRIs or our antidepressants are also very helpful for fatigue. And so you might talk to your healthcare provider about the use of those. And a couple of examples include Paxil and Zoloft. And then on the rare occasions or in the refractory cases where we've tried a number of other things, stimulants also remain an option. So let's switch gears to mobility and ambulation. Again, this is a big part of multiple sclerosis. It is often felt to be the main cause of disability. We have a lot of natural history data of untreated multiple sclerosis. And we know within 15 years of diagnosis, if left untreated, half of the patients with multiple sclerosis will require the use of at least a cane to walk, and 10% of them are already using wheelchairs. Now, I will say that our disease-modifying therapies have significantly impacted the trajectory of some of the mobility dysfunction, but it still remains one of the most disabling symptoms of multiple sclerosis. Gait impairment in MS can be caused, again, by a number of different factors. Part of that is weakness. Foot drop is a very common mobility symptom of multiple sclerosis, but you may have more proximal or hip muscle weakness as well. Spasticity or increased muscle tone and tightness can also impact your fluidity of your mobility and gait. Fatigue, when you don't have the energy, you're unable to get as far as you'd like to go. Sometimes our sensation or our ability to feel the ground can impact our mobility and our balance. So sometimes sensory loss can have an impact. Some patients living with multiple sclerosis have cerebellar dysfunction where their overall coordination is impacted. And this again impacts gait. And vision also plays a role. Usually, patients with foot drop or leg weakness can have what we call a high steppage gait, or their hip kind of bends up so that they can clear the ground. Sometimes with ataxia, it can be more of a wide base gait as well, or sometimes they can take little short steps. Why is this important to us? Because our mobility is a big cause for falls and injury in our patients with multiple sclerosis. I talked a little bit about this in the previous slide, looking at more of the balance and the coordination part of our gait, so severe ataxia. And so that may even involve mobility from transferring from one chair to another. So our mobility issues may go beyond our ability to walk, and this can also result in falls. So balance disorders are a very important thing that we should focus on. How do we manage mobility issues? There are, again, a number of different ways in which we can do it. There are some interventions and therapies that can be helpful. So conditioning programs, gait training with our physical therapy, looking at adaptive exercises. So even though you may not be able to walk or ambulate, there may be exercises that you can do on your chair or on your bed that helps with your core coordination. There are stabilizers as well. And then for some of our patients, there may be the need for assistive devices such as a cane, a walker, or wheelchair to assist in our mobility. Now, many of you may be aware of the use of DALFAMPRIDINE. DALFAMPRIDINE, or AMYPRA, is a medication that has been approved for a number of years to improve walking speed in patients with multiple sclerosis. It works by allowing your nerve cells to communicate more efficiently. So when the information is getting from the brain down to the legs, it can do it better. And in the clinical trial where they looked at the use of DALFAMPRIDINE, about a third of patients actually responded to the treatment. And when they were timed on their walking, they had about a 25% improvement in their walking speed compared to when they were not taking DALFAMPRIDINE. So this may be an option for you as well. Now, part of mobility includes spasticity. Now, spasticity can result in a number of different symptoms for our patients with multiple sclerosis. It can be something as simple as muscle spasms, or can be as severe as contractures. So as we're looking at the pictures that I have here on this slide, these are representation of kind of more of our severe spasticity that results into fixed posturing of our upper and lower extremities. Again, about 80% of patients living with multiple sclerosis have some sort of spasticity. Again, it can be mild involuntary feelings of stiffness and spasms in one or more muscles. It can also present, as I was showing in the pictures before, more of a flexor spasm of a limb or both. But sometimes our patients living with multiple sclerosis will have extensor spasms. So let's say you're trying to get out of bed and your legs go straight out. That would be considered more of an extensor spasm. And that also falls in the spectrum of spasticity. So, what are our goals of managing spasticity? Obviously, we want to improve your functional ability. We want to improve your walking or your transferability, which helps to keep you independent. Sometimes there can be a significant amount of pain associated with the spasticity. So, as we lessen the tone and the stiffness in the muscle, we can also decrease the amount of pain a person's in. And then, as I mentioned before, in the spectrum of spasticity, contractures or permanent um, formation of the hands or feet, we can prevent that from happening sometimes. And then obviously it helps us in easing your rehabilitation procedure. So should you need physical therapy or occupational therapy. So how do we prevent and manage spasticity? I think it's important to identify and avoid triggers that can worsen spasticity. So again, looking at some of the themes of how things affect MS, we see extreme temperatures and humidity can be a trigger for spasticity. Sudden movements, like I mentioned before, getting up out of the bed quickly may send your legs into those extensor spasms. Wearing tight clothes can also trigger spasticity. And the number one thing is infections. So when someone has a urinary tract infection or even an upper respiratory infection, that affects the communication between the nervous system and your muscles, which obviously increase that spasticity. So what can we do? Obviously, stretching is probably the most important thing. Doing active and passive range of motion. So range of motions where you're actually doing the movement, or passive when someone else is doing it for you. Massages are extremely helpful with decreasing stiffness and tone in all muscles. Pool therapy, and there may also be other techniques that the therapist can do, including EMG and electrical stimulation. Again, there are medical management that we can use to help with your spasticity as well. There is the use of antispasmodic medications such as baclofen, tizanidine, cyclobenzaprine, or Flexeril. We may use other medications such as our benzodiazepines, as clonazepam or Valium. Gabapentin has shown to be helpful. And many of our patients who experience those extensor spasms, we find that other anti-seizure medications such as Tegretol can also be helpful. Again, having that discussion with your healthcare provider about what is the best way to manage your individual spasticity or spasm problems is important. Now, for some patients who have local spasticity or spasticity, that involves maybe one or two muscles, BOTOX can be an option. It is an FDA approved therapy in which we use the BOTOX, botulinum toxin, and it's injected directly into the muscles that are affected, and it can help to release them. Now, obviously, this has to be done by a trained healthcare provider, but can be very important or helpful. Now, for patients that experience more of a regional or more muscles involved in their spasticity, primarily the lower extremities, but can also be effective in the lower extremities, a baclofen pump can be installed. Now, this is an intrathecal, which means inside of the spinal fluid administration of baclofen as a liquid. And through this pump, it continuously gives baclofen and bathes the spinal cord, which can be helpful with relaxing its communication to those muscles. Because it's given intrathecally or within the spinal fluid, we oftentimes are able to use much lower doses than we do with oral baclofen. However, requires an invasive procedure, a surgical procedure to insert the pump, and it does require close follow-up with titration of the dose and refilling the pump. But if you have moderate to severe spasticity that's affecting your ambulation or your ability to walk, this may be a good option for you. All right, let's talk about below the belt issues. And one of the big symptoms that many of our patients have are bladder and bowel dysfunction. I don't think we want to follow him into that toilet there. So bladder issues, again, is very common. 80% of patients have some sort of bladder control issues during the course of their disease. Most common symptoms that affect our bladder include frequency and urgency. However, there can be the opposites, or retention, inability to empty the bladder. The frequency may result in increased nighttime urination. It can also result in incontinence or loss of control. And then there can be, for certain people, weak streams. Why do these symptoms happen? It's important that when you have bladder dysfunction, that it be evaluated with testing that is done by our colleagues in urology, because there are really different things that can affect the bladder that results in some of the same symptoms. So there's really three main dysfunctions of the bladder. A person can have a small spastic bladder. That means that's a bladder that every time it gets a little bit of urine, it wants to empty it out. So it does not store urine. And so this can also be felt as an overactive bladder, obviously resulting in frequency, sometimes that urgency, and the incontinence as well. Now, there are some people that can have what we call a hypotonic bladder, or a big floppy bladder, where it fails to empty. So it just collects urine and collects urine and collects urine until the capacity has been overmet. And because of that, you get leakage, you get incontinence, okay? And then there is a dyssynergic bladder. And this is a bladder function in which the bladder squeezes, but the sphincter, or the hole, doesn't open. So oftentimes you get a lot of urgency, I have to go, but when you get there, not much comes out. And that's because the bladder and the sphincter are not working together. And then this can also result in nocturia, or frequent urination at nighttime. So how do we manage these issues? Again, there's lifestyle modifications and adjustments that you can do. Obviously, we want you to stay hydrated, but we should definitely avoid fluid intake later in the day. We want to also avoid caffeine and alcohol, which tends to serve as diuretics and kind of contribute to the frequency. We also want to manage infections, particularly the urinary tract infections or bladder infections. And so drinking cranberry juice or taking cranberry pills can also be helpful. Now, obviously, if you are doing all of those things and you still have incontinence issues Wearing absorbent materials, whether it's pads or underwear, can at least help to keep your clothes dry. Again, there are medications that can be helpful for your bladder dysfunction. And this is why it's important for us to understand what is the true nature of your bladder dysfunction through urodynamic studies, because the type of medication that might be an option for you depends on what type of bladder function you have. So if you have that small spastic bladder or that overactive bladder, medications like oxybutynin or Detrol might be helpful. However, if you have that failure to empty, where it just holds and holds the urine, even though you might have incontinence, really the best way to manage that is to empty the bladder. So that might be things like self-intermittent catheterization, where you insert a catheter to drain the fluid, or the Crede technique, where you provide or put external pressure over your bladder to help empty it out. Now, if a person has a dyssynergic bladder where it's not coordinated, there are other different types of medications that can be helpful, like terazosin or Flomax or doxyzosine. And then if you have a significant problem with nocturia or urinating at nighttime, there are some medications such as DDAVP that can help to decrease your urinary function at nighttime. And so, as I've mentioned in previous slide, having that discussion with your healthcare provider is extremely important. All right, what about bowel problems? Hopefully no one's eating dinner right now. But constipation and diarrhea may also accompany multiple sclerosis. MS affects the communication from your spinal cord to your gut. And obviously that results in decreased motility of your GI tract, and then this results to constipation. Now, the constipation can also impact your bladder. I failed to mention that before, and result in increased urinary frequency. So I think it's important that we understand that we're managing your bowel problems when we're also thinking about your bladder problems. It is also important to know that some of our medications, our dietary habits can also impact our bowel functions as well. So with constipation, you want to review your medications with your doctor. You want to make sure that you're exercising to keep mobility of our GI tract, that you are drinking an adequate amount of water, which I feel is kind of our natural stool softener. And then you can also increase the fiber in your diet or take other supplements such as Metamucil and the such. Now, if you have diarrhea or loss of bowel control, there may be, again, medications and pelvic floor exercises that can be helpful with controlling that. All right. I'm going to move on to heat sensitivity. I do want to make sure that we have enough time at the end of the presentation to answer the questions that are coming in through the Q&A. Heat sensitivity, again, I mentioned earlier, we're coming into the fall, we're coming into the winter time. Maybe this is less of an issue, but we do know summer will be back. And so becoming overheated can temporarily worsen the MS symptoms. And that's primarily what we are discussing when we talk about heat sensitivity. It's not necessarily that you don't tolerate the heat as well. It's just that the heat makes your vision worse, makes your numbness and tingling worse. And this can involve not just our external temperatures or our environmental temperatures, but also what we do to ourselves on a daily basis, such as taking a hot shower, or even if we have an infection. It's felt that even just the small increase in your core body temperature can cause worsening of your MS symptoms. Now, usually for most people, once you cool down, you get over your infection or your fever comes down, symptoms improve. So the best way of managing that heat sensitivity is to keep cool. Spend most of your time in air conditioning environments, and that includes exercising inside, using cooling products such as cooling vests, neck wraps, and bandanas can be helpful. Staying hydrated, again, is extremely important. And keeping with loose, lightweight clothes, particularly when you're outside. Getting into a nice, cool pool can be helpful. One recommendation that I recently received from a patient of mine who actually found online a fan that wraps around her neck, kind of like a headset, and it blows air not only into the face but into the back of the neck. So using techniques and technology like that can be extremely helpful. Keeps you engaged, keeps you outside, keeps you doing the things you like to do. All right, we're almost done. Don't worry, we're getting there. Cognition. This is one of the biggest underneath the surface in symptoms as it relates to multiple sclerosis. Obviously, no other person can see it, but it definitely has a big impact on your ability to function, not only in just your activities of daily living within the home, but also in your jobs or your areas of employment. So this is a big issue that can occur independent of physical disability and has a big impact. So what are the main things that can affect cognition? And this slide has a lot on there that you might find very familiar, but it can primarily involve problems with memory, fuzzy thinking, difficulty with planning and organization, or concentration can be a big issue, and processing delays. That's probably the biggest one. I tell my patients that you oftentimes have slowness of that processing speed. So it takes more time for information to get into the brain, as well as more time for that information to be retrieved and get out of the brain. So this makes things such as multitasking, which is very important in our daily lives and important in our vocational environments as well. But as you can see here, there may be many other things that you can relate to. How do we manage it? It really is compensatory mechanisms. We're making daily lists. We're writing things down. We're keeping Post-its in areas where they are important. We're using smartphones and tablets and setting timers to help keep us organized. And then we have to always set routines and keep things where they belong and put them in the same spot each time. That helps us to at least find what we're looking for. And then develop use task performance routines. And that's really associating what you need to do with an activity that you already do. Probably the biggest thing is when you know you need to take your medication, put it next to your toothbrush. Use your toothbrush. You remember to take your medication. Here are some additional things that you might look to help at least keep you functional with your cognitive difficulties. I think one of the biggest things is prioritize, avoid multitasking, which is extremely important, and then delegating, asking for assistance when you need it, and then taking that time to rest and relax before you start a new task. Make sure you complete the first one. There have been a look at some pharmacological management of cognitive dysfunction with multiple sclerosis. However, I will say that the studies are mixed. There are some studies that show that maybe there may be benefit with some of our medications that are used for our Alzheimer's or dementia patients. And then there are probably just as many studies that show that they're not as effective. So I really think when it comes to the management of cognition, it really boils down to those compensatory mechanisms and then also staying mentally active. All right, our last symptom that we're going to touch on is pain. And MS pain can feel a number of different ways, but it can also feel like this as well. The estimated number of patients that develop pain through the course of the disease varies. It can be as small in some studies as 29% to as much as 86%. And there's two different types of pain that's associated with multiple sclerosis. So there is the neuropathic pain that results from inflammation and lesions within the central nervous system, including the brain and the spinal cord. And pain can also be secondary to symptoms that we've talked about before, including spasticity, fatigue, and even mood disorders. So when we talk about that central neuropathic pain, trigeminal neuralgia or facial pain is probably one of the more common neuropathic pain, but also Lhermitte's phenomenon. So in someone who particularly specifically has a spinal cord lesion, you might find if you bend your neck down, you can get pain that shoots down your spine or into your extremities. And then there is the nociceptive pain. Again, this is more of that musculoskeletal pain, muscle aches, joint pain as well. Psychogenic pain can also exist in our patients with multiple sclerosis. So this may be caused or exacerbated by mental, emotional, or behavioral factors. Many patients with multiple sclerosis, though, do have kind of a mixed type of pain, which involves not only the centrally generated neuropathic pain, but is also coupled with the musculoskeletal impact as well. So lifestyle management is key as well with managing pain. Again, things that are very similar to our spasticity management and our mobility management, range of motion, stretching, massage therapy, light aerobic exercises can be helpful for pain. I would be remiss if I didn't mention some of the mindfulness-based interventions. So meditation practices can also be helpful. Hypnosis has been shown to be helpful. And probably the most commonly looked at intervention is cognitive behavioral therapy. So cognitive behavioral therapy is a process in which we try to reset the thought processes around pain, which also impacts the perceptions of pain and decreases the severity of it as well. There are pharmacological managements and ways that we can also treat the pain. And again, it depends on the type of pain you have, but many of you may be familiar with the use of gabapentin or pregabalin, carbamazepine, another seizure medication that can be helpful with pain. We've also found that our antidepressant medications, such as our tricyclic antidepressants or duloxetine, can also be helpful. BOTOX, I mentioned before, spasticity can be painful. If we release the spasticity, that helps with the pain. For some patients, the use of cannabinoids can be helpful for pain. Our antispasmodic medications can also be helpful. And then for more severe and refractory cases, opioid medications can also be an option. So in summary, again, MS is a chronic disease with no current cure. Although our disease modifying therapies are very helpful at controlling disease activity, it does not necessarily improve our current symptoms. So managing them is just as important. Lifestyle modifications is extremely crucial to the management of our symptoms. And it's also important that you discuss with your healthcare provider about what therapies and interventions that may be an option for you. As you can see in the slide, particularly down at the bottom, oftentimes the management of our symptoms require a multidisciplinary approach, including your neurologist, but our rehab specialists, our pain management specialists, our counselors, and you, of course. So with that, that concludes the presentation of some select symptoms as it relates to multiple sclerosis. I will open the chat box for questions.
Thank you so much, Dr. Sanders. So for some of those that might not know how to ask us their question, let me just give a brief little summary of that. So if you would like to use the raised hand feature in the app, or you can even send your question via chat or through the Q&A. If you'd like to raise your, and those are all down at the bottom. If you want to raise your hand so that you can speak your question, just go to the bottom of the Zoom screen where you'll find the raised hand feature. If you'd like to speak, you're going to have to allow me to unmute you, and I will ask and you can say yes. If you want to do this without telling us who you are anonymously, you can also do that. So let's see, we did have something come in quite a while ago, and I'll go with that one first. And this person said, I am worried about taking medications for fatigue or mobility and being on a DMT. It just seems like that's a lot of chemicals in my body at the same time. You know, what are your feelings about this?
I definitely understand, and I think that's why I really stress the importance of lifestyle modifications as a part of the ways that we manage our symptoms. And so for some patients where there is not the desire to take a lot of medication, I think there are plenty of ways to mitigate some of our symptoms with just those lifestyle modifications that I discussed. However, in those patients in whom we are still doing those things and the symptoms are still unmanageable and unbearable, it is good that we have those options as well. But as I mentioned at the end, it really is a 360 or multidisciplinary approach, and it takes all of those.
Can certain DMTs make bladder problems worse? Aubagio made this particular person have bladder problems a lot more than Tysabri. So she'd like to know about that. And she's on the Tysabri now.
Okay. I am not aware of any bladder issues associated with our disease modifying therapies. However, with medications like Aubagio, we do know some of the common side effects of that would be diarrhea. Also with Tecfidera, we know that there can be GI issues as well with that medication, but I'm not aware of anyone that specifically affects the bladder.
Okay. We also have somebody who asked, are you accepting new patients in Jacksonville Beach? And so apparently they just moved here and they'd like to know if you do.
Yes, our office is open to accepting new patients.
Okay, good. So now let's go to someone. We did have a chat. And what suggestions do you have for the cold? Because when it is cold outside, their hands are barely able to be closed, and that was from Felicia.
Yes, so that is a very great question. So we talked a lot about heat sensitivity, but cold can also affect our nervous system and our function. So that can increase spasticity. That can oftentimes, people can develop what we call Raynaud syndromes, where your fingertips lose a lot of the circulation and become white, and that can affect your ability to move your fingers. And so with that, the goal is to obviously keep your hands warm, particularly if you live in a cold environment, wearing your gloves, warmers inside of your gloves, and then obviously being inside in the heat can be helpful. I'm not aware of any other therapies that can be helpful, but definitely moving your hands. If you've experienced Raynaud syndromes, where it's more of a blood flow issue, sometimes the physicians may consider a blood pressure medication that can help facilitate blood flow. So it depends on exactly what's causing it, but obviously keeping your hands as warm and as mobile as possible can be helpful.
Thank you. Someone asked that they're worried about taking medications for fatigue and mobility and being on a DMT at the same time. It just seems like there's a lot of chemicals. Yeah.
We answered that one already.
Oh, goodness gracious. Okay. Can I get a flu shot 3 weeks after getting the booster shot? Pfizer.
Yes, so it is okay, and has been recommended that you can even get them at the same time based on the CDC recommendation. So there should not be any problems with receiving your flu shot.
Now we do have a couple people with their hands up, and I'm going to try to do that right now. Let's see, participants. Let's see. While I'm trying to do that, why don't we go with, is going to a chiropractor okay? Tawana would like to know that.
So obviously, I would definitely, from an individual standpoint, discuss it with your healthcare provider, because there may be things that are specific to you that may not make it an option. But I do feel, though, that utilizing all of our healthcare providers can be extremely helpful with managing the symptoms of multiple sclerosis, and that does include the chiropractor. However, I do caution my patients to find a chiropractor that is knowledgeable about the nervous system. In fact, in our area, we have a chiropractor that has specialty training in neurology. And so he has been very helpful with understanding how MS affects the nervous system or the body, how stroke affects the body, and can tailor the treatment and the intervention based on that. So I would definitely do your research, talk with your healthcare provider or your neurologist, and determine what might be the best option. But yes, I do think that's part of our multidisciplinary approach.
Okay, I'm going to allow David to ask his question to you.
Yes.
David, go ahead. There you go.
Hi, Dr. Sanders. This was a great presentation. Thank you very much.
Thank you.
No problem. Even though I've had MS now for 24 years, I'd like you to know that last week I was experiencing pain on my right side. It was numb, and I had slurred speech. And I went to do my MRI. It just so happened I had an MRI scheduled. And then afterwards, it came out, my doctor saw the MRI, that I had a new lesion on my left side. He instantly put me on steroids, which is with the inflamed. And now what I am experiencing is in the evenings is hiccups. Why does hiccups occur because of steroids? And is there anything in the evenings? It hasn't begun yet, but I'm just asking, is there anything for hiccups?
I am not aware of anything for hiccups. Obviously, hiccups come from irritability along our diaphragm. I don't think, though, that there is anything that can be used to treat hiccups, but hopefully it gets better after you're done with your steroids.
Yeah, thank you. Yeah. But I just wanted to ask that question.
Oh, thank you
'Cause yeah. Yeah. All right.
for
That's cool.
attending. Yes.
By the way, just so you know, David lives in the Bahamas and comes to almost every one of our Zoom conferences, which is pretty cool. Pretty cool. Okay, so I'm going to unmute Anita also. She'd like to ask you a question. Go ahead, Anita. You have to unmute yourself. Let's see. No, maybe not. Anita. Anita, if you can't unmute yourself, you can just type your question in and we'll ask it to Dr. Sanders. Oh, well, I'm sorry.
No.
Is that you, Anita? No.
Can you hear me now?
Ah, yes, yes, yes. It
Okay.
worked.
Great. Okay, so this is my question. I have a pain pump inside of me. I go to a pain management doctor. He puts the medication in once a month, but I do have the spasticity. So you spoke of the BACLOFEN. Now he's not so sure that that can be put into the pain pump along with the medication. Is that anything that you know of? Or would I have to go to the oral form of that?
So there are some providers that will mix medications in the pump, but it's very difficult because you have to titrate the pump based on 2 different doses of 2 different medications, right? So it's all one reservoir and it's all flowing through. And so it's very difficult and complex to get it just right for each medication dose. So it's not commonly done, but there are some pain providers that have done it. In your case, it may be worth just doing the oral therapies in addition to the pain pump, unless your provider is more comfortable.
So just how common is it to be treated orally with that?
With baclofen?
Yes.
Oh, it's oral baclofen or other antispasmodic medications such as tizanidine, Flexeril are probably our first go-to treatments for spasticity. We don't usually go to baclofen pump unless someone is refractory to using some of those oral therapies. So it's actually more common to have an oral therapy for your spasticity than a baclofen pump.
Okay, great. Thank you very much.
Sure. Thank you for attending.
Okay, so Liz had typed that she's on Ocrevus, had her last infusion on October 6th. She wants to know, when can she get a flu shot or a COVID booster? Not a symptom, just a question.
A very good question at that we're all still trying to figure out. I think COVID has forced us as physicians and the healthcare provider or healthcare system to think on our feet and make decisions very quickly, which we're not used to doing. The general recommendations through the National MS Society and other organizations is really to try to time your vaccinations based on your Ocrevus. So ideally, and that's ideally not a requirement, I am recommending my patients do their vaccination at least 3 months after their last Ocrevus infusion. So what we're trying to do is find a perfect time where we can expect some repopulation of your B cells, and then obviously allow it to produce antibodies before we shut them down again with your next Ocrevus infusion. Very similar with the flu shot as well. So at least 3 months after your last Ocrevus infusion, which, you know, obviously now puts us into next year, but that's ideal. And so I also stress to my patients is we have to do our vaccinations when they're appropriate. You know, I don't want you to wait until the end of the flu season to get your flu shot. Like, let's go ahead and get it now. But definitely talk with your healthcare provider, because guidelines are changing and we all have our different thoughts about it.
Thank you. Dawn asked, she said that she's having serious spasticity issues. She's on 60 milligrams of baclofen, thinking of a pump, but worried about obtaining mobility.
Yes. So when it comes to the baclofen pump, one of the good things about it is you do a trial before they insert the pump. And so what they will do is they will inject through like a spinal tap, inject baclofen into your spinal fluid, and then see how you respond. If your spasticity lessens with the trial, then that makes you a candidate for the baclofen pump. But yes, one of the things that we have to consider with management of spasticity is finding a balance between the tone of your muscles and the strength of your muscles. So oftentimes, the more tone we have, the more spasticity we have, we develop weakness of our muscles. But you're still able to stand because you have a lot of tone. And so what we find is as we release the tone, we uncover the weakness that's underneath it. And so what we have to do with managing spasticity with a baclofen pump is to lessen it enough where we can increase your strength with exercises, and as the tone increases because your muscles are increasing in strength, then we can raise the pump. The pump has the benefit of being titratable, which means we can find whatever dose works for you. And so that's, again, one of the benefits of it. So yes, you are right. It is a delicate balance, but we have to combine the release of the spasticity with improving the strength of the muscles as well.
Great answer. We do have an anonymous question. Can acupuncture help with MS symptoms?
I definitely agree, or think that it can. Again, everyone is different. And so if a patient has found relief with acupuncture for their various symptoms, I definitely say go for it.
Okay. And I have a question also because someone asked this to me. Who would the correct person be to discuss bowel and bladder issues if I had MS? Would that be your neurologist or somebody specific?
Yeah, so it should start with your neurologist. There may be things that we can do at the very beginning. However, if it goes beyond what we are comfortable with, then we usually refer to a urologist. Many of my patients, female patients, actually go to a urogynecologist who is also very informative and knowledgeable about pelvic floor and the bladder as well. So depending on the comfort level of your neurologist, they may refer you to a urologist or a urogynecologist.
Great. I don't think anybody has any questions, except I do have a remark that at the very beginning you had made a comment about giving up control and delegating. Mm-hmm. And I am a control freak, and I know what it's like to allow people or not to want people to help me when I'm not well. Mm-hmm. And I commend you for saying that, because it's really not easy for everybody. And I'm sure there's many people on here that it's difficult to ask people that you love, or people that aren't even people you love, but people that want to help you to do that. And I think it's one of the best things ever. Once you actually get somebody to help you and you realize it's not so bad and it actually feels good. So it's something some of us have to work on. but it brought that to my attention. So I'm glad you mentioned that.
Definitely,
So.
definitely.
Okay, I don't think we have any more questions, and I really appreciate you being here, but that's all the time we have for now. Did you have any comments at the end, or would you like me to say good night?
We can say good night. Thank you, everyone, for attending.
Thank you. So let me just tell you, if you've missed any part of this, some of you came in a little bit later of this conference, it will be replayed on msfocusradio.org and available on demand on our MS Focus SoundCloud page or our YouTube page. Remember to follow MS Focus on Facebook, Twitter, Instagram for times and access information. And our next teleconference is going to be next Wednesday, November 3rd at 6:00 p.m. Eastern Time. The presentation is going to be in honor of National Caregivers Month, which is November. And it's going to feature a discussion titled Tackling MS Together, a program for you and your care partner. This is going to be a panel discussion. It's going to be made up of 3 different couples. Each couple has at least one person that has MS. One couple, actually, both of them have MS. And it should be quite interesting. And I would encourage all of you to attend and your caregivers to attend with you. So care partners, rather. So our sincere thanks to all of our attendees for your participation, especially to Dr. Sanders, who's been kind enough to take time out of her busy schedule to be with us tonight. And I hope we can see all of you again next time. Have a good night, everyone.